Have you noticed the silence? It's the sound of thousands of veterans quietly walking away from the system designed to support them. In 2025, we are seeing an unprecedented exodus from the VA, a mass disillusionment that goes far beyond simple frustration. It's not just a few disgruntled individuals, it's a systemic fracture, a crisis of confidence that is reshaping the landscape of veteran health care in America. If you are a veteran, a family member, or someone who cares about those who served, you need to understand why so many are choosing to navigate the complexities of civilian life and private insurance rather than step foot inside a VA facility again. This isn't just about long wait times anymore. This is about trust, quality, and the sheer mental exhaustion of fighting a bureaucracy that often feels like it's actively working against you. We're going deep into the 7 core reasons why the VA system is hemorrhaging patients, starting right now with the fundamental barrier that breaks the spirit of so many who rely on it. The first, and perhaps most immediate, breaking point for veterans is the agonizing, impenetrable wall of wait times and access barriers. We hear the numbers quoted constantly, but the reality on the ground is far more brutal than any statistic can convey. Imagine receiving a diagnosis, a serious one, perhaps a cancer scare or a progressive neurological condition, and then being told the specialist appointment you desperately need is 6 months out. 6 months is not a timeline for effective treatment. It is a sentence of anxiety and deterioration. Veterans often enter the VA system with complex, interconnected conditions, TBI, chronic pain, and mental health issues that require coordinated, rapid responses. But the VA, despite its best efforts and hardworking staff, is fundamentally bottlenecked. This isn't just about scheduling primary care, we are talking about highly specialized services. If you live in a rural area, the nearest VA medical center might be 3 hours away, turning a simple checkup into an entire day lost, a day of missed work, and fuel costs that drain meager disability payments. The promise of the Mission Act was supposed to alleviate this, allowing veterans to access community care when the wait exceeded standard metrics or the distance was too great. But the implementation of community care is often a bureaucratic labyrinth itself. You get approval for outside care, but then the local provider refuses the VA's payment rate, or the necessary paperwork gets lost between the VA scheduler, the third-party administrator, and the community clinic. The veteran is left stranded in the middle, holding a referral that is functionally useless. This constant struggle, this endless loop of phone calls, hold music, and conflicting information burns veterans out. They realize that the fight for health care is sometimes harder than the fight they undertook overseas. They ask themselves, is the free care worth the cost to my sanity and my health timeline? For thousands, the answer is a resounding no. They choose to pay out of pocket, scrape together funds for private insurance, or rely on employer plans, anything to bypass the gatekeepers and the endless, demoralizing wait. The sheer complexity of scheduling, coordinating, and confirming appointments becomes a full-time job for the veteran or their caregiver, adding immense strain to already difficult circumstances. The system's inability to scale its specialized services to meet the growing demands of aging and wounded veteran populations is a ticking time bomb, and 2025 is the year that bomb is exploding into an exodus. Every delayed appointment is a delayed diagnosis, and every delayed diagnosis chips away at the life expectancy and quality of life for those who sacrificed so much. The frustration is palpable, leading to a profound sense of abandonment. This leads us directly to the second massive systemic failure: quality of care discrepancies and inconsistent expertise. When a veteran finally gets through the wait and sits down with a provider, they often face a lottery of medical competence. The VA system is vast, and while some facilities boast world-class specialists and cutting-edge research, many others struggle with staff retention, outdated equipment, and a rotating door of temporary contractors. Veterans with service-connected injuries require highly specific, deep knowledge of military medicine, the long-term effects of burn pits, blast exposure, toxic substances, and the unique physiological and psychological sequelae of combat. Too often, they encounter general practitioners or specialists who treat their complex, multifaceted conditions as isolated incidents, lacking the institutional knowledge to connect the dots back to their military service. This results in misdiagnosis, or worse, the dismissal of symptoms as normal aging or psychosomatic. The veteran knows their body. They know the changes are tied to their service, but they are met with skepticism and a lack of belief. This experience is incredibly invalidating. Imagine explaining a rare tropical disease contracted during deployment only to have the doctor consult a basic medical textbook in front of you. This lack of specialized expertise forces veterans to become their own medical advocates, constantly researching, challenging diagnoses, and demanding specific tests, a burden that should never fall on the patient. Furthermore, the hiring process within the VA is notoriously slow, meaning that facilities often operate perpetually understaffed, forcing existing doctors and nurses to take on impossible caseloads. This leads to rushed appointments, reduced attention to detail, and increased burnout among the dedicated staff who remain. When the quality of care becomes a gamble, veterans start seeking stability and certainty elsewhere. They want a provider who understands the difference between standard PTSD and complex PTSD resulting from prolonged deployment stress. They want a surgeon who has successfully operated on blast injuries before. When the VA cannot consistently guarantee this level of expertise across its network, especially in smaller or rural clinics, veterans seek the known quantity of private hospitals, even if it means navigating the financial hurdles. The perception that the VA is a second-tier health system, despite its enormous budget, is a driving force behind this departure. This systemic inconsistency in care quality is not just frustrating, it can be life-threatening, and veterans are increasingly unwilling to risk their health on the chance they land a good provider in a well-funded facility. The sheer volume of malpractice claims and internal quality reviews, often hidden from the public eye, further erodes confidence. The third reason for the mass departure is the soul-crushing reality of the broken appeals and disability claims process. For many veterans, the VA is not primarily a healthcare provider. It is the entity that determines their financial stability through disability compensation. The claims process is designed, intentionally or unintentionally, to be a gauntlet of bureaucracy, delay, and denial. A veteran files a claim linking their chronic knee pain or debilitating migraines to their service. This is the start of a multi-year ordeal. The initial decision is often a denial, forcing the veteran into the appeals process. This process is a black hole of paperwork, waiting, and re-examinations. The average time for an appeal to be fully resolved can stretch to 5 years or more. Think about that. 5 years waiting for the compensation needed to afford housing, food, or specialized treatment. This protracted delay is not just an administrative inconvenience. It is an economic crisis for the veteran and their family. They are forced to live in limbo, unable to plan or stabilize their lives while the VA slowly processes forms. The system relies heavily on the veteran's ability to meticulously document every single symptom, every doctor's visit, and every life impact, often requiring them to relive traumatic events repeatedly during compensation and pension (C&P) exams. These exams are frequently conducted by third-party contractors who may spend only 15 minutes with the veteran, resulting in reports that contradict years of medical history. The veteran feels unheard, doubted, and scrutinized. The burden of proof is impossibly high, and the standards for evidence seem to shift constantly. Veterans often have to hire expensive lawyers or accredited agents, further reducing the financial benefit of the claim just to navigate the complexity. The emotional toll of this fight is immense. It transforms the act of seeking help into an adversarial relationship with the government they served. Many veterans report that the stress of the claims process exacerbated their underlying mental health conditions, when the system designed to provide financial relief instead causes profound financial and emotional distress. Veterans begin to view the entire VA structure, health care, and benefits as toxic. They realize that disconnecting entirely, focusing on private employment, and managing their own financial stability is a healthier, more predictable path than remaining tethered to the endless uncertainty of the VA claims system. The frustration over presumptive conditions, where the VA slowly and often only after decades of advocacy acknowledges the link between service and illness, further fuels the anger. Why must veterans fight legislative battles for years just to prove what science already confirms? This bureaucratic warfare is a primary driver of the 2025 exodus, pushing veterans toward systems that offer clarity and predictability, even if they come at a higher immediate financial cost. Moving on, the fourth critical area driving veterans away is the pervasive issue of mental health stigma and insufficient specialized care. While the VA has made strides in acknowledging the mental health crisis among veterans, the execution of care remains deeply flawed and insufficient, especially for complex cases. The stigma associated with seeking mental health treatment within a government institution is still very real. Veterans worry that admitting to severe PTSD or suicidal ideation could jeopardize their security clearances, their disability rating, or their professional standing. This fear leads to underreporting and delayed treatment. When they do seek help, the care model is often generalized. A veteran with severe combat-related trauma, moral injury, and TBI needs highly specialized, intensive therapy that goes beyond standard weekly counseling sessions. They need providers who understand the unique culture of the military and the specific nature of deployment stress. Unfortunately, the VA often struggles to retain these highly specialized clinicians. The result is long waiting lists for effective, evidence-based therapies like prolonged exposure, PE, or cognitive processing therapy, CPT. Veterans are instead offered medication management or generic group therapy, which, while helpful for some, fails to address the deep-seated trauma of others. The lack of 24/7 crisis support that truly integrates mental and physical health services is another major failure. Point: a veteran in crisis often finds themselves navigating a complex system of emergency rooms, psychiatric wards, and scheduling offices, rather than a seamless, supportive continuum of care. The most tragic consequence of this failure is the persistent, high rate of veteran self-harm. When veterans see their peers struggling and failing to get the urgent, effective help they need, they lose faith in the system's ability to save them. They realize that the best, most innovative, and often most discreet mental health services are found in the private sector, in specialized trauma centers, or through nonprofit organizations that are agile and focused. The bureaucratic inertia of the VA makes it difficult to adopt new, cutting-edge therapies quickly. By the time a new treatment protocol is approved and rolled out across the massive VA network, private clinics have often been using it for years. Veterans are tired of being treated like numbers in a study or waiting for the bureaucracy to catch up to the reality of their suffering. They are seeking immediate, effective, and confidential care, and in 2025, that search is overwhelmingly leading them outside the VA's walls. The sheer volume of veterans needing this care, combined with the difficulty of recruiting and retaining specialized staff in high cost of living areas, creates an insurmountable gap that veterans are no longer willing to tolerate. They are looking for healing, not more hurdles. The fifth major factor fueling the exodus is the confusing, often frustrating reality of YPST, privatization, and community care confusion. The VA system is no longer a monolithic entity. It is now a hybrid model, heavily reliant on the Community Care Network, CCN. While this was intended to increase access and reduce wait times, the implementation has been chaotic and has created a two-tiered system that confuses veterans and providers alike. Veterans are forced to make complex choices. Do I stay within the familiar, if flawed, VA structure, or do I risk the unpredictable nature of community care? The confusion begins with eligibility. The rules for when a veteran qualifies for community care are constantly shifting based on distance, wait times, or specific medical needs. A veteran might be approved for community care for one condition but denied for a related condition, forcing them to juggle multiple providers in different systems. This lack of continuity of care is a huge problem. Private doctors often struggle to access the veteran's complete VA medical records and the necessary communication between the VA and the community provider frequently breaks down. Test results are lost, medications are duplicated, and the overall coordination is abysmal. The veteran becomes the unwilling intermediary, carrying files and trying to explain the complexities of their VA benefits to a private practice administrator who has never dealt with the system before. This friction point is exhausting. Furthermore, the integration of private care has led to a perceived degradation of the VA itself. Resources and focus are sometimes diverted to managing the external network, leading to internal staff feeling undervalued and internal services being cut or reduced. Veterans who prefer the specialized, veteran-focused environment of the VA worry that the system is being deliberately hollowed out in favor of privatization. They fear that the unique expertise built up over decades, the understanding of military culture, the integrated approach to service-connected disability is being diluted by general civilian medicine. This sense of institutional drift, where the VA is neither fully public nor fully private, creates profound uncertainty. Veterans crave stability and clarity in their health care, and the current hybrid model delivers neither. They realize that if they are going to deal with private providers anyway, it is simpler to cut out the VA middleman entirely and manage their own insurance and billing, gaining control over their choices and avoiding the administrative nightmare of the CCN authorization process. The financial incentives within the private system are also different, leading to potential conflicts of interest or a lack of understanding regarding the VA's mission. Sixth, the veterans are fleeing due to persistent technology and data management failures. In an era where commercial healthcare systems are rapidly adopting seamless electronic health records and patient portals, the VA remains mired in outdated, incompatible, and often frustrating technology. The massive, multi-billion-dollar effort to transition to a new electronic health record, EHR system, has been plagued by delays, cost overruns, and catastrophic failures in deployment, leading to patient safety issues and staff frustration. The fundamental problem is interoperability. The VA system struggles to communicate effectively internally, let alone externally, with community providers or the Department of Defense, DoD. Veterans often have medical records scattered across different facilities, sometimes even existing only on paper charts in dusty storage rooms. When a veteran moves or transfers care, the necessary medical history often fails to follow them completely. This technological deficit is more than an inconvenience. It is a clinical danger. Imagine a doctor trying to prescribe complex medication without full knowledge of the patient's history of allergies or previous adverse reactions. This lack of a unified, reliable, and accessible digital record forces providers to make incomplete decisions and requires veterans to constantly recount their medical history from scratch. The patient portal, while improved, is often clunky and difficult to navigate, especially for older veterans or those with cognitive impairments like TBI. Simple tasks like requesting prescription refills or sending secure messages to providers become complicated, multi-step processes that frequently time out or result in error messages. Furthermore, the data security within the VA has been repeatedly questioned, leading to concerns about the privacy of highly sensitive medical and personal information. Veterans, many of whom have worked in highly secure environments, expect a higher standard of technological competence and security than the VA has consistently delivered. The continuous reports of system crashes, data loss, and the failure of the expensive new EHR rollout are not just news stories. They are tangible threats to continuity of care. When veterans see private hospitals and modern health systems utilizing streamlined apps, telehealth platforms, and instant data sharing, they recognize that the VA is operating in a technological time warp. They choose to move to systems that offer modern convenience and, crucially, technological reliability, rather than relying on a patchwork system prone to failure. The technological gap is a symbol of the VA's broader inability to modernize and adapt to 21st century healthcare demands. Finally, the seventh and perhaps most emotionally resonant reason for the 2025 exodus is the profound loss of trust and accountability. Over the past decade, the VA system has been rocked by repeated scandals, manipulation of wait lists, excessive prescription of opioids, cover-ups of poor performance, and instances of severe patient neglect or death. While dedicated employees continue to do incredible work, the institutional response to these failures has often been perceived as weak, opaque, and focused more on damage control than genuine reform. Veterans feel that there is a fundamental lack of accountability at the leadership level. When serious misconduct occurs, the public rarely sees swift, decisive action. Instead, the process of internal review drags on, and often, high-level officials responsible for systemic failures are simply transferred or allowed to retire with full benefits rather than being held responsible. This lack of consequence sends a devastating message to the veteran community. The institution protects itself before it protects its patients. This erosion of trust is perhaps the most difficult thing to repair. Veterans inherently trust the chain of command and the institutions of the government, but repeated betrayals of that trust through negligence, dishonesty about wait times, or the failure to address known problems have created a deep-seated skepticism. They look at the massive budget allocated to veteran care and wonder why the outcomes remain so inconsistent and why the bureaucratic hurdles persist. They see the system as being too big to fail, and therefore too complacent to truly fix itself. The feeling is that the VA is an institution for veterans, but not truly of veterans, often failing to incorporate their lived experiences into policy and practice. When a veteran must fight their own government for basic medical care and financial stability, the psychological contract is broken. They realize that relying on the VA means perpetually accepting a lower standard of performance and a higher level of risk. This realization that their well-being is not the absolute priority of the institution is the final straw for thousands. They are choosing self-reliance, private care, and independent advocacy groups because they believe those entities offer a more honest, transparent, and responsive relationship than the governmental agency tasked with their care. The flight is not just about medical necessity. It is a vote of no confidence in the VA's ability to govern itself ethically and efficiently. The mass departure of veterans from the VA in 2025 is not a temporary fluctuation. It is a clear, undeniable signal of a system under immense stress, a system that has failed to adapt to the needs of a modern veteran population. We have seen that the reasons are multi-layered: the exhausting delays and access barriers that delay critical care, the inconsistent quality and lack of specialized expertise across facilities, the years of bureaucratic warfare required to secure earned disability benefits, the pervasive stigma and inadequate specialization in mental health services, the crippling confusion and lack of continuity caused by the hybrid community care model, the dangerous technological failures and data management deficits, and underpinning it all, the profound loss of trust stemming from systemic lack of accountability. Veterans are not abandoning the VA because they are ungrateful. They are leaving because they are prioritizing their health, their sanity, and their financial stability. They are choosing predictability over bureaucracy, quality over convenience, and self-advocacy over institutional reliance. For the VA to halt this exodus, it must do more than simply promise change. It must demonstrate radical transparency, enforce genuine accountability, and fundamentally restructure itself to put the veteran's immediate well-being above all bureaucratic inertia. Until that happens, the silence of those walking away will only grow louder, a stark reminder of the cost of institutional failure. Think about the veteran in your life. Are they getting the care they deserve, or are they fighting a system that should be fighting for them? The answer to that question defines the future of veteran healthcare in America.